which we have with us.
Okay. Well, let's go ahead and call the meeting to order. And Teresa, are you on? Would you take the roll call? So I guess she is not on.
Okay.
Veronica, I think you said that Donna was staff person today.
Yes. I don't know. Donna,
Yeah,
do you
I'm
have?
here. We can go ahead and do roll call.
Okay.
Okay, Elizabeth Parton,
Here.
Nana Eisner, Susan Stewart, Dr. Jerry Roberts,
Here.
Teresa Aldridge, Dr. Garth Bobrowski,
Here.
Dr. Steve Compton,
Here.
Dr. John Muller, Dr. Ashima Gupta,
Here.
John Dadds, Dr. Catherine Hanna, Barry Martin,
Here.
Kent Gilbert,
Here.
Mackenzie Wallace, Anissa Franklin, Sheila Schuster,
Here.
Brian Proctor,
Here.
Peggy Rourke,
Here.
Eric Wright, you have 10 MAC members here.
I apologize. I'm in here. I apologize. I'm on, my father's caregiver didn't show up, so I apologize. I had to jump away for a minute. Thank you. This is Kathy Hanna.
Okay, that brings us to 11 MAC members present.
Okay, so we do have a quorum. So we can go ahead and move forward. Peggy, I saw that your hand was raised. Did you need to say something?
I think she had it up originally, Beth, to indicate that she was here.
Okay. Thanks, Sheila.
Yeah.
Okay, so next on the agenda is approval of the minutes for May. Would somebody like to make a motion?
I'll move their approval. This is Sheila Schuster.
Garth Bobrowski seconds.
Okay, any discussion? All in favor, say aye.
Aye. Aye.
Anybody opposed? Okay, minutes are. Next, we'll move on to old business. And first of all, I would like to extend a thanks to the Department of Medicaid Services and Commissioner for updating the Rural Health Clinic Reg 907 KAR1:082. I think those updates to that regulation are good and important, and I thank you for moving forward on that. So having said that, we'll just move into the old business. First up is, when will Medicaid regulations promulgate? I'm sorry, when will Medicaid promulgate regulations to reimburse certified professional midwives?
Good morning. This is Lisa Lee, Commissioner for the Department for Medicaid Services. At this time, we have several projects that we're working on, and many of them from legislation that was passed in this session and last session. And so while we understand the request to include certified professional midwives, at this time, we are not considering adding it, and nor will we be doing that in the near future. But as you know, Dr. Parton, just from the conversation and, just acknowledgement of the rural health clinic changes, we do continue to listen to the MAC recommendations, and we'll work with you all to make sure that we're making policy changes that are very pertinent to the program and that will enable our members to be seen and receive the services that they need. But right now at this time, given our workload and stretching of our staff based on all of the projects we have that we're working on, we are not going to move forward with reimbursement regulations to reimburse certified professional midwives at this time.
Okay, thank you. And just as I continue to do, I'll continue to keep that on the agenda, and maybe one of these days it'll be a yes.
Madam Chair, may I raise a question? I'm new to the MAC, of course, so I'm trying to gain my feet here, and perhaps Ms. Lee can help me. So, though that has been enacted in law that it's okay, what's the consequence of not promulgating regulations? Does this mean that nurse midwives will not be paid or reimbursed?
No, nurse midwives are currently reimbursed. This is a new category. They're certified professional midwives. They are not nurses. They are regulated by the Board of Nursing, and they must pass national certification exams in order to be certified and be able to practice under the regulation of the Board of
Yeah.
Nursing. But they're not reimbursed for their services by Medicaid.
But I thought wasn't there legislation this year that enacted their reimbursement?
No.
Wasn't that what 575 did?
No, no, they're not reimbursed for their services. They are recognized and they are able to practice. They're just not be reimbursed by Medicaid.
I see.
Madam Chair, I think Kent is thinking about the community health workers, which was House Bill 525. And that was
Thank you.
that was in legislation, Kent.
Thank you, Sheila.
Yeah.
Okay, next item is continuing Zoom meetings. We had talked in the past about meeting in person in September. And so I just wanted to bring this up again with the group to see if you're comfortable meeting in person in September, or do you want to meet by Zoom? So any discussion on that? Any thoughts?
I would largely think it would have to do with where we are numbers wise, which are not currently good. I know that it would be lovely to see everyone in person, but I think maybe it could, if we are not out of the red as a substantial number of our counties are, I'm not sure that both travel or meeting in person is as wise as it might be otherwise.
Thank you, Kent. Anybody else have any thoughts on that?
Yeah, if we don't do it in September, as the year progresses and the winter hits, we might as well as postpone it until next summer.
So are you in favor of meeting in person or by Zoom, Barry?
If we can't meet in September, we probably should just put it off until spring. Or attempt to do it in the spring.
Okay, any other thoughts?
This is Garth Bobrowski. I would recommend just going with the Zoom for our September meeting, and it's like Kent said, just maybe wait and see what the numbers are looking as the year goes along. For the in-person meeting, I know we had agreed to go to once a year to try to do a in-person, but I think this September might be too early.
Okay, so as much as I would love to meet in person with everybody, because I miss seeing you and I miss that interaction. I miss our little side conversations before and after the meeting. But I'm inclined to also agree that since we've got counties in the red, that it might be wiser to meet by Zoom. We haven't heard from all the MAC members. So if there is any MAC member who would like to meet in person, please speak up.
I think the Zoom meetings are the best for our gas prices, and I'm trying to work and with the COVID, and I just feel like it's the best for me.
Okay, thanks, Peggy. Well, then I don't hear any objections, so I think we'll go ahead and meet by Zoom in September.
Sounds good. I still think that we should have it on as a goal for us to meet in person once a year, but find an opportune time to do that.
Yes, yes, I agree. And we can revisit that again in September if you like. November should still be okay for travel. If COVID numbers are down and people are feeling comfortable, we could change our mind. But for now, let's just say that we will continue Zoom meetings until next spring.
Okay.
Okay, next up, and I see myself on the screen now. I just got a little head, but anyways, okay. Update on missed and canceled appointments. How is the reporting going? And is there a common thread as to why patients are not showing up for appointments? I guess this would go to Commissioner or somebody from DMS.
Yes, thank you, Lisa Lee again. We have been monitoring reports. For example, we pulled up the latest quarterly report in this last quarter ending in June. We do show 10,640 logged missed appointments in the system. And again, our information is only as accurate as the providers report. Of those 10,640, a little over 7,000 or 67% of those were just a no-show, no reason provided. We also are showing that about 11% or a little over 1,000 individuals rescheduled their appointments. Transportation issues are low on the list. Only 73 of those 10,000 reported as transportation issues. 12 childcare issues, but again, the biggest was the no-show and the no reason provided at 67%. And I believe that the MCOs that are presenting today, they may have more information on some of the no-shows specific to their population.
Okay, that's kind of concerning that it's kind of what we thought too. People are showing up and they're just not showing up. There's no reason.
And I think we could put it into perspective too, but again, though all we know are those no-shows that are logged, but we could also go back and for this same quarter, we could run a report showing the actual total number of individuals who did show up to get a percentage of Medicaid population that's not showing up for their visits. Because when we look at the 10,000, in a quarter, that does sound like a lot. But when we compare that to the claims and the individuals who did show up, we'll see what the actual percentage is per quarter, and we may need to start looking at it in that lens also.
Okay.
Madam Chairman, Steve Compton. Well, I think the no-show is probably underreported though. So when we start looking at those percentages, we need to keep that in mind. We know who showed up, but the no-shows are not every practitioner is reporting.
Not only that, but if you use overall utilization, that will include walk-ins.
Good point.
And yeah, and thank you, Mr. Compton, for that observation. We do know that the information is only as accurate as we have in our system, and if it is logged. So something that we, still want to keep an eye on. And I think at the last MAC meeting, Dr. Bobrowski, you may have even mentioned somebody who had missed 11 appointments. And if we can find those individuals, reach out to them just to see what we can do to help get them into the office to their appointments, because that's the overarching goal of this project, is to try to identify those individuals, particularly those that miss one or more appointments so that we can find out why they're missing, help them get into their appointments, and make sure that they're adhering to their medication protocol and other measures to make sure that their health that they're taking care of their healthcare needs.
I think we also need to stress to the providers that's there and they need to use it. And if they don't use it, then it doesn't give you good numbers to leverage.
Yeah, I'd like to follow up on that. We discussed this at the Behavioral Health TAC, and we were going to ask for a report on who is it that is reporting. I know that you all can break that down, Commissioner, by behavioral health versus, different specialties and so forth. And I think it would be really helpful to have that information as well. We'd sure like to get after our behavioral health providers to make sure that they're using the portal. Thank you.
Yeah, and I think keeping in mind the overarching goal of we're trying to number one, reduce the number of no-shows, but number two, make sure that individuals are getting to their healthcare appointments and taking care of their healthcare needs. So I think I don't know that we have had enough information about the no-shows out. I know we have trained providers, it's in the system, but I don't know that we have communicated widely enough the importance of logging those no-shows. So maybe we can do something in the department to kind of help get the providers to go ahead and start logging those no-shows so that we can help them bring their members into their offices for treatment.
This is Dr. Ashima Gupta. I know that our office, for example, we've had so much turnover since COVID that I know that reporting is not happening at my office. It's just with the turnover, it just gets, that's like the least on the priority list to take care of. So maybe even just like a quarterly email that's sent out to the providers, I think will really help.
Thank you for that recommendation.
I think also it will be good to look at the overall patients that are showing up comparing to the ones that don't. But I also would want to temper that by saying that even if it's just 2 patients a day for a practice, that's a lot, because that's 2 slots that could be filled by somebody else who wants an appointment that day and who's put off because there's an appointment scheduled. So that looking at that, I think, is important, but also I think we need to keep in mind that it may not get to the crux of the problem.
Madam Chair, I think Dr. Terrio has her hand up.
Thank you, Dr. Schuster. I was just wondering, well, it would be nice to know what the providers are doing when a patient no-shows or misses an appointment, because that's the point in time that it would be nice to intervene. And I wonder if there's some best practices out there, so if a patient doesn't show, reaching out to that patient right away to see what's going on, to try and get them in. And again, it might be a reminder, but it also might be a car problem, whatever else. But I'm just wondering what the providers themselves are doing on that day to help patients attend their appointments.
That's a good idea.
We're finding across the board, dental, behavior, and medical, that a lot of it is just common offenders, the same offenders with multiple no-shows. And then you spatter in a few that doesn't do that on an ongoing basis. But across the board, it seems like there's a constant population that does that.
Well, that's even better. So knowing that ahead of time, what's being done to reach out to those patients in particular to help.
I think we're all trying to call, confirm appointments, and even when you confirm them, they still don't show up. And even our registration clerks has gotten to the point where they already know, okay, we're scheduling them, but they've not showed the last 3 or 4 visits, they're not going to show again. So that's where we need help from the MCOs and Medicaid and other insurance companies to help target those that we know that we're wasting time on, and the ones that doesn't show because of whatever sporadic reasons, then those are ones that may have legitimate reasons or not. I think it's a targeted population we're looking for.
Thank you.
Yes, I would agree with that. At our clinic, we've purchased a reminder, a text reminder through our EHR, which added quite a bit of expense. So far, I can't say that it's made a whole lot of difference. We do call people when they miss their appointment and try to reschedule. Sometimes they will schedule another appointment. Sometimes they just tell us they'll call back.
Sometimes at our office, if they miss several appointments, like Commissioner Lee alluded to, we finally just get to the point and say, on a day you can come, you call us first thing in the morning, and if we get an opening, we'll call you. Otherwise, you can call on another day, because at some point as a business, we just, and these are adults, enough's enough, act like an adult and be responsible for these appointments. I hate to be, we don't mean to be mean or crude, but some offices, you miss a couple appointments and you're just dismissed. Now we haven't done that, but it's just like last Thursday night about 7:30, I got a phone call. A lady called. I don't know how she got my personal cell phone number, but called my personal cell phone number and said, "Doctor," well, she messaged me on Messenger first. Then she called me 5 minutes later and, "Oh, I'm in pain." But well, she's already missed 4 appointments this spring and summer. Well, I didn't come in on that night. I already was into something else. And then she didn't call Friday to be seen. We had to call her Tuesday to be seen, and we got her in and took care of her. But, these are adults, and I just think we just need to sometimes just quit spoon feeding them and just say, well, this is the reality of you missing your appointments. Yes, it's just like Dr. Parton says, we've got that text reminder system, and that adds an expense to your office running. And I think a lot of these ideas are good, but at the same time, you've got to be really careful on the administrative burden that we put on our front office staff, our assistants and nurses and whoever helps to keep up with this paperwork, because that's kind of one of the common things that we hear is that the administrative burden is just getting unsustainable for some of these programs.
This is Dr. Ashima Gupta. I totally agree. I mean, on Monday, we're in a private practice, totally independent. I had 10 no-shows on Monday. And with decreasing reimbursement from insurance companies, it makes it very difficult to sustain a practice, especially with inflation. And we have to pay our employees so much more than we did 3 years ago just to keep them.
I agree. It's just Medicaid has given us a tool to use. And if we don't use it and give them the information, we can't get them to hold our patients accountable. I think if we can give them the information, then it's up to Medicaid to help with the MCOs hold our patients accountable that are missing these. I think we're just going to keep struggling. At least they've given us a tool to use. We need to try to use it and give them the information somehow.
Commissioner, just to your question related to what are MCOs doing, Jeff Dick from Humana. I will think we're doing the best of our ability to take action. So any member on the report is getting a letter just ensuring that we're stressing the importance of coordinating and communicating with providers. Any member in case management, either behavioral health or physical health, is getting a phone call to ask about barriers to their appointments. And then members who are frequent flyers, members who hit the report more than once, are also getting live phone calls to try to understand why our members aren't maintaining their appointments. But we hear the frustration and we're willing to innovate and do any recommendations, but we're taking action with the information we do have.
This has been a really good discussion, and I think we've hit on some points here. I think providers need to work harder providing this information to DMS, and then DMS can in turn work on the information that they receive to help us come up with a solution for this. So I appreciate everybody's input. It helps a little bit, you know, when you're dealing with the problem, to hear that you're not alone. So thank you for everybody speaking up. Next up on the agenda is update on reimbursement for multiple visits on the same day.
I think I'm going to turn it over to the Senior Deputy Commissioner, Veronica Judy Cecil. She's been working on this topic. So Senior Deputy Commissioner.
Thank you. So this is something the primary care TAC brought up, and we are continuing to do our deep dive in this. We're working with Myers and Stauffer, who does all of our rate development for our FQHCs and RHCs, so that we can really understand the impact to the program. Part of their work is to research across states what other states are doing. The challenge there is that every state is different. I think you always hear when you see one state Medicaid agency, you know one state Medicaid agency. So we're all different in how we administer the program, but we're still gathering that information, and we will be presenting that to the primary care TAC so that they can take that information and utilize it as, you know, whether or not they want to present a recommendation from that.
Okay, so do I need to keep this on the agenda for the next meeting then?
My recommendation is to, you know, allow the primary care TAC to, because it's on their agenda, to allow them to review it, since that's where it came out. But I certainly will defer to the MAC on how they want to handle that.
Okay, I think that it's an issue with primary care, but if I'm not mistaken, it's also an issue with other specialties, because people have a primary care appointment and they have a specialty appointment on the same day, and that's where we're running into the issue.
Well, yeah, but it's specific to the three entities that receive a supplemental payment: the FQHCs, the RHCs, and the CCBHCs. You gotta love acronyms.
Yeah, right.
But the specialty, that's what we're diving into. So it's not just behavioral health or a medical physical health appointment. It would also include, you know, whether or not a specialty, you know, some other specialty like dental, or, you know, just some other provider type service. So that's what we're looking at.
Okay.
This is Steve Shannon. The 4 CCBHCs are just new to this world since January, but it clearly is a question that's come up amongst ourselves as well. How does this play out? So, and is there a disincentive to scheduling multiple visits on the same day for a person?
So I just want to remind everybody how the rate gets developed. It's about the scope of services that are provided. So it includes, you know, all the services that are provided, all of the practitioners that provide those services. And that gets utilized to develop the rate. And so that's why it is a, you know, a daily rate. And if there's a change in scope, then you know, that can trigger a change in the rate. So, you know, it's supposed to be contemplated in the development of the rate for all services delivered on that date. That's the model. But again, we're taking a look at it. We understand and have heard the concerns of the providers on this. And so we're gonna take a look and see what we can find out and work with the providers on if there's some, a different model that they're interested in adopting. I will tell you, there are good and bad with each model, and there are winners and losers with each model. So that I think all has to be taken into consideration.
And this is Barry, and I'm on the primary care tech, and Medicaid has been working with us, and we are reviewing the information they're giving us. And I think just leave it on there, and I think hopefully we'll come to a resolution or a recommendation to either take it off or recommend some action. So we're working on it. I would recommend just to keep it on this agenda, and hopefully we'll be able to address it.
Okay, thank
Is
you.
that all right, Deputy Commissioner Cecil?
Oh, I defer to you all.
Okay.
Okay, thanks, Barry. So I will keep that on the agenda then. Okay, next is hepatitis C prenatal screening, number of cases and number treated. This issue came up at previous meeting, and I think those numbers were going to be presented today.
Hello, this is Dr. Terrio. I surprisingly was having trouble getting the numbers. I think I'm pulling them wrong. The numbers I got were less than 1% of our pregnant women were being screened for hepatitis C, and I really don't think that's correct. I looked at one of our state university partnerships, and their number was 11% of pregnant women in Kentucky Medicaid getting screened for hepatitis C. I was very happy with that number because it was much more than 1%, but as you know, it really should be 100%. So we're still looking into that. Just to give people background, Kentucky is the second leading state for adults with hepatitis C. About 2% of our adults have hepatitis C in the state, and we lead the nation in pregnant women who are positive for hep C. About 8% of babies that are born to moms who are hep C positive will end up becoming positive themselves for hepatitis C. And we have a wonderful treatment. So it's easy to treat, honestly. And so we really need to screen and find out every single person that has it so we can treat them and cure them. That's a long way to say I don't really have specific numbers right now, but I have been working on it, and I will try and get those for next meeting.
Okay, thank you. So we'll put that on the next meeting then. If that's correct, that's alarming because isn't that mandated that screening be done?
It is. Yes. And I'm actually very scared that the number, the 11%, is actually accurate. So.
Wow. Okay. Well, hopefully we'll have better news next meeting.
Hope so.
The next item on the agenda is just a reminder that our next update on maternal child health will be in November. And then before we move on to updates from the commissioner, I wanted to just say that for our election today, we have one candidate for each position. And so at the end of the meeting, we will do our election. But if anybody is interested in running, please let us know so you can be added to the slate. Otherwise, we'll just do a voice vote of approval. Okay, next up is reports from Commissioner Lee.
Hello, thank you. So I'm sure if many of you may have been watching the news today and just see the devastating floods in Eastern Kentucky. We have seen on the news several people losing their homes. Some people are missing. Definitely just devastation due to all the flooding. We have been in touch with our MCOs relating to some of the actions that they're taking to make sure that individuals have access to their medications. And Dr. Fatima Ali is also working with MedImpact to make sure that individuals who may need emergency prescription fills can get them, focusing on individuals who may be in case management or an inpatient. Looking at some of our long-term care facilities to see if there's any impact there. But again, just trying to do everything we can to make sure that individuals in the eastern part of the state that are being impacted by these floods have access, particularly to their medications and healthcare services if they need them. So we'll, more to come on that, but definitely are working with their MCOs. And I would like to definitely thank all of the MCOs who have initiated contact with the department to see what they can do in order to help individuals in the eastern part of the state. Our MCO partners, as you know, were very critical in Western Kentucky during the tornadoes and helping ensure that not just Medicaid members, but other members and the other individuals in the community had access to health care and the supplies that they need. So we just definitely like to thank the MCOs for all they're doing right now for the communities in Eastern Kentucky. One update, a little bit of sad news is that those of you who may know Lee Geis and work with her, her last day will be tomorrow. She is retiring effective August the 1st. We definitely hate to see her go. She has a wealth of knowledge and has been, as you know, been very instrumental in many of the TAC meetings. In her, as she leaves, Justin Derringer will be acting director for a while. So if you have any questions for Lee, you can reach out to Justin. The other bit of news that we have, I'm going to turn the conversation back over to Senior Deputy Commissioner Veronica Judy Cecil, and she is going to give you an update on Medicaid reorganization activities that have been taking place. Veronica.
Thank you, Commissioner. Donna, I'm going to share my screen. Okay. Hopefully you all can see that. It might be a little hard to, I'm going to zoom in, but can you all see the floor chart? Yep. Okay. So what you're seeing here is at a high level, what changes have been made to Medicaid. And we reorged as we had a reorganization as of July 14th. 2 of our divisions are unaffected, and that's program integrity and fiscal management. We renamed 3 of our divisions, and I'm going to go through those. And then we created 2 brand new divisions. So let me zoom in. So the division of the information system is a new division. What we did last year is we did move over staff who works on Medicaid systems, and we have a lot of them. And it's very complicated and complex, and we decided to bring those over from our sister agency that handles all of the information systems for the cabinet. We brought them in-house so that we could better prioritize Medicaid's needs in the systems. Several of them we'll be going through procurement, and we have to get approval from CMS on our financing of the system. So we really wanted to bring those folks in-house and work so policy and our IT experts can work hand in hand and more closely to ensure that those systems are reflecting what Medicaid needs in those systems. So as part of that, we moved, when we made that transfer last year, we created 2 new branches. We just moved them over into the Division of Information Systems and have created a 3rd branch called Data Management. So the Division of Healthcare Policy was renamed. It was formerly Policy and Operations, which was Lee Geis's division. We've made some major changes here, the biggest of which is creating a maternal and child health branch. We're super excited about this opportunity to focus our staff and our efforts on these two critical areas of health. As you know, with Dr. Terrio leading us, we're doing a deep dive into maternal health and trying to figure out ways that we can improve outcomes. So now we're going to have a branch dedicated to that. Our benefit policy branch will become the physical health branch. And again, solely focused on policies around healthcare services and how those are reimbursed. We'll be looking forward to, being able to do a better job of keeping updated on trends and innovation in healthcare policy through that. The Division of Policy, our new division, excuse me, new name, Division of Quality and Population Health, was formerly Program Quality and Outcomes. Program Quality and Outcomes used to do both quality and managed care oversight. And we felt like it was really we needed to break those out into separate divisions, because again, our goal here is to drive outcomes. I think you've heard Commissioner Lee mention on several occasions, we want to be more than just a payer of claims. We want to be a driver of healthcare policy to improve the outcomes of our members. So this division is being refocused to do that. We've created an Equity and Determinants of Health branch. This branch, as it says, will be focused on how do we address the inequities and disparities across the state that affect our members. CMS, the Centers for Medicare and Medicaid Services, our regulatory agency, is very much focused on how can we better address the determinants from the Medicaid program. It's allowing MCOs to utilize funding for those determinants, and that's housing and food and clothing and jobs. And so how can we improve the overall health of our members, not just for healthcare coverage? The former Disease and Case Management branch has been renamed Population Health, because we want to look through that lens as we develop our policies. We want to be able to focus on those chronic conditions. We really need to be, we just understand we need to do a better job of ensuring that our policies and our programs can address those across the program. And then our MCO quality branch has just become the quality branch, again, focused on, we have a quality strategy we're working on right now. It's going to be looking at and doing more reviews of the services, of the coverage, and ensuring that we're paying for quality services. And then a research and analytics branch that will provide us the necessary data so that our policies are data informed. We're making changes based on that data and ensuring that the data is usable. Is quality data and actionable. The Division of Health Plan Oversight is the other brand new division. This will be the division that takes over all of the oversight of the managed care organizations. But I'm also happy to announce that the Health Benefit Exchange, which does the marketplace, the qualified health plans, has moved into this division. And the Director for Health Benefit Exchange has come over, Edith Sloan, and she is now the new Director for the Division of Health Plan Oversight. We wanted to do that because this division is going to help us ensure consistency and continuity of care across the different plan, from Medicaid to qualified health plan, and potentially in between. If there's I know you all are aware that we're talking about a basic health plan. So all of that would fit under this one division, so that we have people that can see across that continuum and understand it and help people navigate it. So as a result, we created a new appeals and complaints branch. So all of the appeals and complaints related to the Medicaid program and for MCOs and for qualified health plans will fall in that branch. We renamed the MCO contract management to just contract monitoring. So there will be, again, enforcing the MCO contract, but also looking at the agreements with the qualified health plans, and to make sure that everybody's in compliance. And then we moved from policy and operations, we moved eligibility and enrollment into this branch, again, because we want that continuity and consistency in understanding how eligibility is affected by all the programs, and be able to seamlessly move people across. So I think the other really great change here is our former Community Alternatives Division has been renamed the Division of Long-Term Services and Supports. We decided to align all of the long-term and community programs into this one division. And that, again, is part of our logic of making sure there's consistency and continuity. People often move from long-term care into community programs and from community programs into long-term care. So now we have all of that under one division. We created the long-term care facilities branch. That's the nursing facilities, the ICFIDDs, so those folks, all anything related to nursing facilities or nurse aid training, all of that has moved over to long-term care facilities branch under the renamed Division of Long-Term Services and Supports. What we're hoping is that this is seamless to providers and to members. Again, some of it has just been a change in name, but a refocus for the department. And what we're hoping to gain from this is bringing on additional staff. Our resources have always been limited, and we have a fabulous staff, fabulous employees here under the department. But because our day-to-day we're so overworked and overwhelmed, this will give us the opportunity to bring on some additional staff with different skill sets. For example, bringing on people who are familiar with population health, bringing on some diversity in the skills that we already have, and being able to focus where we should, which is, improving the lives of our members. So that is a really quick and high overview. I'm happy to take any questions.
Veronica, the columns in white, are those still there, or are
yes, right? There was no change to the Division of Program Integrity and to the Division of Fiscal Management.
Okay. And then secondly, could you send all of the MAC members a copy of this flow sheet?
Absolutely, happy to do that.
Veronica, this is Sheila Schuster. I have two questions. One is, at some point, can you tell us who are in those big boxes that head up those divisions?
Absolutely. So I'll just go real quick, but we'll add the names for the version we send. John Hoffman is Acting Director for Division of Information System. John has been with Medicaid for a long time. He was previously the Assistant Director in the former Division of Program Quality and Outcomes, but he's now Acting Director of Information Systems. Angie Parker, who was over Program Quality and Outcomes, remains the Director of the renamed Division of Quality and Population Health. So Angie Parker will still be there. As we mentioned, Lee Geis was formerly Healthcare Policy, leaving August 1st. So Justin Derringer will be as Acting Director there. Edith Sloan from the Health Benefit Exchange has become the new Director, excuse me, for the Division of Health Plan Oversight. And then Pam Smith remains the Director for the renamed Division of Long-Term Care Services and Support.
And who's in that Division of Program Integrity?
Yeah, That's Jennifer Dudinsky.
Oh, yeah,
Yep,
okay.
she hasn't changed. And then Amy Richardson is the Director of Fiscal Management.
Thank you. And then I have one more question, and that is at the very top. And of course, I love seeing behavioral health right up there at the very top of your chart. But I'm a little confused about what that means, because you've got.
Yes, sure. I'm happy. Yeah, I'm happy to explain that. So behavioral health does not have its own branch. It's basically a unit. It's a program, and it does come under the Commissioner's office. Leslie Hoffman, the other Deputy Commissioner, heads that program.
Okay, I knew that she was there. I guess I was thinking that it would go under, where you have physical health and the other categories.
Yeah, so I will share, Dr. Schuster, that we had lots of conversations about whether to create a new branch for behavioral health, but we really want to keep it under the Commissioner's office.
Well, we like having the Commissioner's clout up there with behavioral health, so I'll take that. Thank you. Appreciate it.
You're very welcome. Are there any other questions?
Okay, anything else from the Commissioner?
I do not have any additional updates at this time, and I do apologize. I'll have to be dropping a little early today, but you all will be in very good hands with the Senior Deputy Commissioner and the rest of the Medicaid staff that are on here. I will be on for a while longer, but I will be dropping maybe around 11:30 or so. So no other updates at this time.
Okay, thank you. And then next up then is an update on the basic health planning and unwinding.
So we are on pause right now with the basic health plan. As you know, we had started out with an original start date of 1/1/23. We did listen to some of the concerns, particularly potential carriers who were concerned about maybe being able to develop a adequate provider network. So is on pause right now, and we will give further updates as we get them. Related to unwinding, we, as you may know, the public health emergency has been extended again. We have a communication plan that is ready to go. Our main concern and focus for unwinding is going to be on our members, making sure that we have accurate and updated addresses for them so that we can reach out to them. Also want to make sure that our provider community knows that if you have someone in your office and you notice that they have a change of address, if they're a Medicaid member, can instruct them to contact the cabinet if they have not, to update their address. Again, as we go forward, we'll have a 60-day notice from prior to the public health emergency ending from CMS. So the current one extends into October of 2022. So we will again provide information as that becomes available. And then we are also right now, we're going through a lot of the flexibilities that we have been afforded under the public health emergency and implementing some of those as we can, so that when the public health emergency ends, there will not be a huge disconnect or interruption of services, particularly around telehealth. We have updated our telehealth regulation. The only thing that we're waiting on as far as telehealth is concerned is guidance from the federal level regarding HIPAA compliant platforms. As you know, during the public health emergency, providers have been allowed to use Zoom and FaceTime and those sorts of things. So we're waiting to see if we'll be allowed to continue those platforms in telehealth. But again, waiting on information from the federal government. And again, our goals are to comply with all requirements, all state and federal requirements. We want to prevent any unnecessary terminations in the Medicaid program. Again, that's why it's really important for us to have accurate, updated addresses. We are working with their managed care organizations to kind of stagger mailings based on individuals who need to be redetermined when the public health emergency ends. So as you are aware right now, the department cannot terminate anyone except for presumptive eligibility members, individuals who pass away, individuals who request to be removed from Medicaid, or individuals who move out of the state. So right now we do have individuals who have never done a redetermination, or who may have forgotten that they need to do a redetermination when the public health emergency ends. So again, definitely focusing on our member population and keeping everyone enrolled that qualifies in the program. And we want to have some sort of smooth transition for those individuals who may lose coverage but qualify for a qualified health plan. And as the Senior Deputy Commissioner reported, we now have Connect and the qualified health plans, the state-based exchange in our department, which will make some of those transitions and communications a lot easier. So again, just focusing on our members. And I think that I will turn it over to the Senior Deputy Commissioner for anything I've missed and to talk about our communication strategy.
Thank you. As the Commissioner mentioned, we are working on a communication strategy, and that was for very different reasons. One is for member, obviously ensuring that the member understands what action he or she might need to take to maintain eligibility. The other is for the provider. We want to make sure providers understand what's happening. There were some flexibilities that we implemented related to providers. So making sure how all the providers understand how the unwinding affects them. But also it's important for the providers to understand what's happening to the member. And we want to make sure our advocacy organizations that we know we're going to need to utilize to help get the message out. And we do want a common message. We want to make sure everybody is telling everyone the same thing to try to reduce any confusion. So we will have a very comprehensive communication plan. And what we don't want to do is roll it out too early, because we don't want to create chaos or fear or anxiety unnecessarily. And so that's why we just continue to monitor the status of the public health emergency. The 60-day notice will be what will trigger our moving forward with the communications. And until then, as the Commissioner mentioned, we really just want, we're asking members and we're asking kind of everyone just to encourage members to make sure their information is updated in our system. So we have contact information. We do plan to leverage the managed care organizations. The CMS has allowed states to utilize them kind of a little differently than normal, including being able to update contact information and us be able to rely on that without a secondary verification. We're going to work with our MCO partners on reaching out to their members specifically affected. And so I think that'll maximize the resources on how can we keep these members covered. And we're going to be using lots of different ways of communication, which is what this slide speaks to. Just really quickly, so that you all understand the way we process renewals. There's an automatic processing that goes on behind the scenes once we flip the switch to restart everything. So that'll happen behind the scenes. What that does is a lot of people can be what's called passively renewed. We have all the information, we can verify all that information. There's no additional action needed from the member. And so those folks go down the passive renewal lane and they'll get a notice of renewal, no additional steps. It's the ones that have to do something actively. So they have to respond to a request for information because we couldn't verify something. So it's the active renewals that we're going to focus on. Right now, we estimate around about 180,000 people may be subject to an active renewal that changes every month. Sometimes the system's able to verify somebody, because this is all kind of going in the background anyway, even though we're not doing any terminations, it's happening. And that's where we can kind of identify how many people may be subject to an active renewal. So we'll send out that active renewal packet. I mean, yes, that renewal packet. They'll get it. It'll tell them exactly what it is that we need. They upload that information. They can do that various ways. Then it'll be reviewed and either a notice of renewal will be issued or the notice of denial. Of course, we always, the member has the opportunity to request a review or to appeal any denials. And then we're going to send this out to everybody. I know it's probably a little hard to see, but this just goes through a scenario timeline. If, for example, the PHE does end on October 13th. I think what's important for everybody to realize is that, again, we start the process pretty early, and we give at least 40 days notice to the member that they, may potentially be deemed ineligible. So this sort of walks through kind of what that looks like. So if the PHE ends in October, November would be the first month that we could terminate people. So again, it kind of goes back 2 months. We'll start the renewal process the next month, the month before a termination, a potential termination. They'll receive notices. They'll be able to work on those notices. We'll be working closely with the MCOs, making them aware of which members are potentially subject to a termination. They'll be doing outreach. We're going to work very closely with our connectors and other organizations to make sure there's a ton of support out there for people so that we don't let anybody slip through the cracks. And then, again, November, the end of November would be the first time since the pandemic and the public health emergency that we might have to terminate somebody. So we'll get this out. One other thing to note is that the home and community-based programs, the 1915C waivers, we have what's called an Appendix K that has created the flexibilities for those programs. It expires 6 months after the PHE ends. So we'll be continuing to monitor those. So they'll have a different timeline and different communications, but just wanted to note that.
Okay, thank you. So that was a very thorough explanation about what's going to happen with the unwinding. So at our next meeting, what I guess we'll need to know is an update on the basic health plan, and then where we expect we are in that process finding.
Right, we'll know by the next meeting whether it's been extended again. The public health emergency will be extended again. So, again, until that 60-day notice, things are just status quo. We're not doing any terminations. The flexibility stay in place. It's just when we get that 60-day notice, we'll start doing major communication.
Okay, thank you. And then you're going to send us all of the slides, right?
Sure will, and we'll also post it to our website.
Okay, perfect. Okay, so we have a little under an hour and a half left for our meeting. And so I'd like to ask the tax to keep their reports short so that we can get through all of those and have time for any questions that were left over for Aetna and Anthem, and then the reports from Humana and Molina. So let's go ahead and, again, please just keep your report short. Tell us any pertinent information that we need to know, and then your recommendations so that we can get through all the TAC reports quickly. First up is behavioral health.
Good afternoon. We met on July 14th and we had a quorum, approved our minutes. We continue to have an issue around payment for members who have dual coverage. We've solved it, I think, for Medicaid and Medicare, but not for Medicaid and commercial insurance. So Angie Parker from DMS was very helpful in giving us some follow-up information. We also had a discussion about the no-show data portal, and we will be asking for more detailed information about who the providers are who are making reports. We had a very important discussion, I thought, about provider credentialing. And at our next meeting, we will have someone there from Kentucky Hospital Association. They have worked with Aperture to create a credentialing alliance, and 3 of the MCOs belong to that. So we're trying to get a handle on how that works and how it will help providers speed along the credentialing process. We also looked at telehealth, and we were very happy to have Jonathan Scott, the reg guru from CHFS, talk to us about 907 KAR 3170. I advise you all to look at that. That's the recently adopted reg from Medicaid about changes in telehealth. So that was very helpful, and we had lots of questions answered as well. We also are following the work of the interim task force in the legislature on emergency medical services. I've spoken to you all before about the problem of transport, particularly for people with behavioral health issues, where the ambulance drivers and EMS are taking the position that they don't have to transport, quote, those crazy people, end quote. So we worked on House Bill 777, and we're continuing to monitor that task force. We did have one recommendation. The Behavioral Health TAC recommends the DMS issue frequently asked questions document to members and providers on telehealth services based on their most recently approved regulation. So that is our only recommendation. We will meet again September 8th, and I think that's record time for me to talk about behavioral health. Thank you.
Thank you, Sheila. Could you give me the citation again for that regulation?
Yes, it's 907 KAR 3:170.
Thank you.
Yeah, well worth looking at. And if the department can do an FAQ, I think it would be super helpful to providers as well as to consumers for that matter. And that was our recommendation.
Okay, thank you. Next up, Children's Health. Okay, Consumer Rights and Client Needs.
Good morning, everyone. Emily Beauregard with Kentucky Voices for Health, and I'm the chair of the Consumer TAC. We met on June 21st, and we met remotely using Zoom. We had a quorum present. We did discuss at that time wanting to go to some sort of hybrid meeting option and have one meeting a year where we're in person together, similar to what the MAC has discussed. And I think everyone was in agreement with that decision, but with the rising COVID rates, I think that we'll be putting that off for a little while yet. We were very pleased to learn at our last meeting that Kentucky has received approval from CMS to lift the 5-year waiting period for legally residing pregnant immigrants who are otherwise eligible for Medicaid. This is something that our TAC has recommended in the past, and we think that this is a great way to improve maternal health, a good step in that direction. I know that's been a priority of the MACs recently, and we were also happy to hear that the governor has approved all appointees for the new Health Equity TAC. We hope those meetings will begin soon. And again, another great opportunity to work on reducing disparities in maternal health. We discussed network adequacy again at this meeting. We recognize that, most Medicaid members are really unaware of network adequacy rules and how to request an out-of-network provider when a particular MCO's network isn't sufficient. And we really appreciate that Angie Parker put together a draft memo in response to a request that we had made for information that could be shared with consumers that explains the rules, their rights, and how to change MCOs if the network won't meet their needs. We're going to review this draft and discuss it again at our next meeting, and may have some recommendations that come out of that. We also revisited the state's spending plan to invest in home and community-based services with Arpa funding. And we understand that that's on hold right now due to a directive from the legislature to increase provider rates. But we also understand that CMS requires, a rate study to be conducted to justify any rate increases. And all that said, it seems that this has perhaps delayed some plans in paying for onboarding costs of PDS employees that are hired by waiver participants. And the waiver participants are unfortunately having to shoulder the burden of these costs for onboarding their employees while they're on incredibly limited and fixed incomes. And so that is a concern. And it may be that I'm not completely understanding this issue, but it continues to come up. And it's an issue that's being raised by one of our TAC members who is a participant in a home and community-based services waiver. So we have submitted to you, Dr. Parton, and to Aaron, our report, along with a statement from Arthur Campbell, who is one of our TAC members, about this issue. So please share that with MAC members if you can. I'll be sure to, I believe it was Donna who was staffing today. I'll be sure to share it with you as well. And I think that covers, most of what we discussed at our last meeting. We didn't have any recommendations this time, which is unusual for us, but I do expect to have a few at our next meeting. And I just wanted to touch on a couple of things that were discussed earlier. Transportation is a huge barrier to people getting to their appointments. When you were talking about the no-show rates, we know that transportation is always cited as the primary barrier that people face. And so thinking about how non-emergency medical transportation can help to address some of that no-show rate, and what we can do to improve access through the NEMT program, I think is a good role for us and perhaps for the MAC to start exploring. And then, community health workers, I think, could also be part of the solution there. And, thinking about the unwinding and what we need to be doing in order to make sure that people are aware and responding to those renewal notices. I hope that providers will be part of the solution. When people are coming in to see their provider, asking if their address is up to date and making sure that they are updating it in Connect, or that the provider is filling out a form to update that address, I think could be really beneficial. There is a form that exists that most providers aren't aware of, but we know that people often don't find out that they've been disenrolled until they seek care, either at a provider's office or go to the pharmacy. And so that's just something else that I would suggest keeping in mind. And I think that's it for us.
Okay. Thank you, Emily. Next up is dental.
Yes, this is Dr. Garth Bobrowski. We don't have any specific recommendations from the TAC at this time, but we did want to express our disappointment in our request from last time about a fee increase. We want to thank the primary care TAC for bringing it to the forefront of the lack of dentists and access to care from Eastern Kentucky. But I'll be brief here, but even the KDA and the executive committee of the KDA and the executive board of the KDA had reached out the part of the DMS was response was based off of an ADA report that is not 100% accurate. And they were showing that I've got part of it here that Kentucky ranked the highest in the nation in terms of reimbursements at 104.8%. And folks, that's just not so. But as was reported earlier, I know with one of the research things on hepatitis C, she said that, well, some information came in as 1%, some of it came in as 11%. And sometimes, as you all know that have done research or been involved with that, sometimes your research design and methodology can affect your outcomes of your research or sway your thoughts on your research. But this is kind of why a lot of dentists have quit seeing a lot of the adults. Is the number one thing was the low reimbursements. Number two was the failed appointments. Number three was the administrative burden that they're put under. But I did want to thank Dr. Caudle and Avises for their increase in some of the fees to the participating dental providers. And I did want to thank them for that. And I'll just leave it at that for today. Thank you.
Thank you, Dr. Bobrowski. Next up is nursing home care. Home health care.
Good morning, everyone. Evan Reinhardt with the Home Health TAC. The TAC met on June 21st and had some robust discussion on reimbursement rates, which continue to be a concern in our space, as well as some other ongoing old business topics. And we did not have any recommendations at this time.
Okay, thank you.
Thank you.
Hospital.
This is Russ Rinaldo from the Hospital TAC. We met on June 14th and we had a quorum. We had no recommendations. We talked, DMS provided us a metric report on the iPro and denials, and we were reviewing that. We also had discussion on incarceration data, and adjustments and fixes with that continue to be ongoing, and a few others that are in my report, but for sake of time, that's all.
Okay, thank you. Intellectual and developmental disabilities.
This is Rick Chrisman. The IDD Tech met on July 19th. The main order of business was that we learned that the state is still waiting on approval from the federal government, CMS, for approval of the rate increases that are contained in the state budget. Beyond that, we had no recommendations. Thank you.
Thank you. Nursing TAC. I believe the nursing TAC put in the chat that they had to leave early. So I don't think they had any recommendations, and they can submit a written report. Optometry.
Steve Compton. We met on May the 5th. We had a quorum. We had some great discussions. We meet again next week, but we have no recommendations.
Okay, thank you. Persons returning to society from incarceration.
Yes, this is Steve Shannon. We met on July 14th. We had a quorum. We have no recommendations, but we continue to get updates on the 1115 waiver amendment for folks returning from incarceration. I think our real work will start then. We did hear updates about other state initiatives that will impact folks returning. One is Apple Red encourages people being hired. I think employment's a big part of that. And the Recovery Ready Communities. There'll be a Senate Bill 90 Implementation Council that will look at diversion as people get arrested, so they don't go into incarceration, they go to treatment. And the Opioid Abatement Advisory Commission. We got an update about that commission as well in the Attorney General's office. Thank you.
Thank you. Pharmacy?
Yes, this is Ron Poole with Pharmacy TAC. We met on July 20th, had a quorum. I'm cutting this in half, even though it's going to seem lengthy, because we had a couple of kind of hot topics for sure. And trying to cut it down in negotiations with legislators for House Bill 48 in 2021. It passed in March of 21 and it went into effect July of 21. The Kentucky Department of Medicaid Service was excluded from this law due to the discrepancy in the Centers for Medicare Services not recognizing pharmacists as healthcare providers. And I want to reiterate that point just then. I'm sure you can imagine how embarrassing it is for pharmacists who fill for 48 million Part D recipients nationwide that were not still recognized as healthcare providers. But the Kentucky Department of Medicaid Services would have to have filed for a waiver, which they can, in order to comply with this law. The Kentucky Department of Medicaid Services have received $827 million from drug rebates from Senate Bill 50 that we got passed in 2021, didn't go into effect till July of 2021. So looking at potential ample funds to develop and create clinical pharmacist services, taxonomy codes, billing codes. To date, all we have is a HCPCS code in order to develop just for consulting with immunizations. Clinical pharmacy services, just brushing over. We did this, I was on the board of pharmacy when we developed a lot of these clinical services for pharmacists that we worked in correlation with Kentucky Medical Association, also the Kentucky Academy for Family Practitioners, where we do acute uncomplicated UTI testing. All this is point of care testing, group A strep testing, flu prophylaxis and antiviral testing, colorectal cancer screening, TB testing, pharmacogenetic testing, anticoagulation clinics and models, to also being able to dispense under protocol for tobacco cessation and alcohol use disorders, travel health prophylaxis, allergic rhinitis, emergency contraception, anaphylaxis treatment, where people can just come in and get an EpiPen in an emergency situation and it be legal. Same thing with naloxone. They can come in and get a prescription without having to worry about getting a doctor because it's by a medical doctor's protocol. Expanded immunization protocols, which has been around the longest of all of these. Oral contraceptive evaluation. Opioid use disorders, working with monitoring and potential interaction and intervention with those. The long-acting injectable education and administration for antipsychotics, all of your adherence education and packaging that's been going on for some time, and then all of your just educational programs on self-care conditions, self-care with diabetes, OTC, probiotics, interview and recommendations, and things that a lot of people know about as transitions of care, chronic care management, and remote patient monitoring. The motion was, due to the charge of the CMS memo on 5/12 of 22, which states that state Medicaid programs are expected to give all provider types authorized to administer COVID-19 and childhood vaccinations under the HHS COVID-19 PrEP Act declaration opportunity to enroll as Medicaid providers and receive Medicaid payment, not only for actually delivering or injecting vaccines, but also for standalone vaccine counseling about these types of vaccines provided to beneficiaries for eligible for EPSDT. And due to the passage of House Bill 48, an insurer or third-party administrator for such insurer shall provide reimbursement to a pharmacist for a service or procedure at a rate not less than provided to other non-physician practitioners if the services if the service or procedure is within the scope of practice of pharmacy, would otherwise be covered under the policy plan or contract if the service or procedure were provided by a physician, advanced nurse practitioner, and physician assistant. In addition,
If they were to resale shop for $30, they're that Rothy.
in addition to all other compensation that may be reimbursed to a pharmacist under this chapter, the employer insurance or payment obligor shall be liable for reimbursement of a pharmacist for service procedure at a rate not less than that provided to other non-physician practitioners for the service or procedure. The PTAC asks for the MAC to ask and encourage the Kentucky Department of Medicaid Service to enroll individual pharmacists as Kentucky Medicaid providers. In addition to PTAC, asks the Kentucky DMS to create taxonomy codes, billing codes specific to pharmacists performing vital clinical services, and create equitable and unbiased pharmacist reimbursement models for providing these clinical services, which greatly improve the quality of life and the status of one's healthcare for all of our Medicaid recipients. The second discussion was on Nadaq pricing, which is what our reimbursement is based on for our prescription drug claims. We'd heard plenty of reports from all over the state of some reimbursement not being up to date on Nadaq. Adrian McCormick with Med Impact educated us, the PTAC, on how Nadaq prices are updated, from manufacturers increasing prices to then updating first data bank, to Nadaq being updated by Myers and Stoffers, to Med Impact and Magellan databases picking up these price increases from Nadaq database. The process may take 2 to 3 weeks. In addition, the website and report generated by the national or the Nadaq comparison data is rather lengthy. This last one dated July 20th, it was just issued. So what Medicaid does is they go back, or excuse me, what Magellan and certainly Med Impact do is they go back and they backdate some of the price increases because of the process taking 2 to 3 weeks, which is nice, but to be able to go back and query over 21,000 different NDC numbers is rather time consuming. And me personally, I'm decently tech savvy. So I was able to create a little piece of software that allowed me to look at the 21,825 different NDCs and compare them for the date ranges that were backdated to see which drugs I could rebill or reverse and rebill. Not everybody has that ability to do that. So the TAC, the motion was the PTAC requests that all pharmacy Medicaid providers be informed of the website and report that can be accessed, which informs each provider of drugs that have had their price increases backdated are eligible for reverse and rebilling for increased reimbursement. In lieu of the difficulty of pinpointing with such a lengthy report to go through, we asked that Med Impact work with us on creating, with the pharmacy providers working on us on creating and sending an electronic report to every pharmacy enrolled with Medicaid Med Impact, and each of the pharmacy claims that were reported by the Nadaq as a price updated for each pharmacy system. That's a request and a motion for consideration. I have spoken to Adrian McCormick in person, and she was nice enough to get on the call with us the other day. But that is our request, and that is the end of my report. Sorry about the length. Thank you. I did cut it down.
I just make just a couple of comments if possible. Do we have time?
Sure.
Just quickly, I just did want to say, I want to voice some concerns too, as far as with the provider, being able to enroll as providers, as pharmacists, because I just wanted to say that, during the pandemic, pharmacists have provided, we've been open continually during the pandemic and provided over 70% of the vaccinations across this Commonwealth. And CMS has recognized pharmacists as being an important healthcare provider, not only in the delivery of vaccination services, but also in consultation. In light of that, they've clearly stated this in their expectation in the memo that they did send to Medicaid providers. And it's hard for me to understand how this can be ignored as a directive. Also, I wanted to, just say that now as we're faced with this challenge in distributing Paxlovid in many areas of our state who have limited access, pharmacists can help in this endeavor. But because we don't have a provider number, it's very challenging because there's no reimbursement for this. And those who are providing this understand what that takes. There's a lot of time involved in looking for drug interactions and making sure you have lab levels and that type of thing. Without that ability, it makes it hard. And so many of our our patients and may, be challenged with having access to Paxlovid. So that's another area where I find this challenging. And during the PAC meeting, there was a comment made that part of the reason for not recognizing pharmacists was due to fiscal considerations. There were some other points made, but that was one of them. And that is somewhat challenging for me to understand. As Dr. Poole has submitted in his report, the services that pharmacists do provide focus on public health. And I do ask the cabinet if the charge of DMS is to focus, primarily on fiscal savings, that comment was made, which kind of bothered me, or on providing access to care. As Dr. Poole said, we found the savings from Senate Bill 50 were $800 million. And in the rebates alone, it seems that some of these savings could be reallocated to help provide these valuable public health services to the beneficiaries that we serve. And that's why I think this is a very valuable thing. I think that the Department of Medicaid Services should follow the directive of CMS and look to providing pharmacists with an ability to bill for these services and be listed as a Medicaid provider. Thank you.
Thank you. Any other comments? Okay, then we'll move on to physician services.
This is Ashima Gupta. We did not meet.
Thank you. Primary care.
Yes, this is Barry Martin. Our chair, Mike Cottle, could not make it today, so I'm giving the report. We met on July 7th and we had a quorum, and we continue to work well with DMS and the MCOs on various aspects, and appreciate Dr. Bobrowski's comments about us tag teaming with the dental tech on trying to help the dental shortage and the dental disparity throughout the state. Which leads us to the two recommendations from the primary care TAC. They both relate to dental. One is for a state policy review of the current dental workforce shortages in Kentucky, including the use of dental auxiliaries to expand healthcare workforce capacity. That recommendation is supported by DMS. The other recommendation we had was related to dental, of course, and it's for a policy review relating to current dental enrollment levels in state-funded dental colleges, in-state and out-of-state dental graduate retention levels and dental scholarships, dental loan and loan forgiveness options for Kentucky dental graduates, review the equity of current dental fee reimbursements provided by the state Medicaid program and its MCO contractors, and a review of policies and programs that support local coordination, care coordination, and the integration of dental prevention and treatment services into hospitals, public health departments, school health clinics, FQs, and RHCs, of which DMS supports that recommendation as well. So those are our 2 recommendations.
Okay, thank you. Next up is therapy services. Okay, looks like we don't have a report from therapy services. So I'd like to have somebody make a motion to accept the recommendations from the tax. Somebody please make a motion.
This is Barry, I'll make a motion.
Second,
I'll second it.
who's that?
Teresa.
Thank you, Teresa. Is there any discussion? Okay, all in favor, say aye.
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 Any opposed? Okay, the reports are accepted. Next,
Madam Chair, this is Sheila Schuster. I actually thought as a member of the MAC that I would receive the written reports from the tax. Did I miss that, or have they never been circulated to the MAC members? This is only my 2nd meeting.
they should be. We should receive the reports from the tax.
And I assume that they would be circulated prior to the meeting so we could look through them beforehand.
So they're not always presented to DMS prior to the meeting. It's after the meeting, after the report's been given and the recommendations have been approved, that then we send them out. But I will double check to make sure the reports are going out along with other communications.
Yeah, I don't remember getting them after the last meeting. That was my first meeting on the MAC.
We did, and also the response back to the tax. The MAC has not been receiving the response from DMS for all the tax. We used to, and we haven't been. So I would like to request that all the MAC members receive the response to the recommendations from the tax.
Okay, I'll double check with Erin, but I'm pretty certain she sent those out about 2 weeks ago, but we'll follow up.
Okay, thank you.
Thank
Deputy Commissioner. Will these reports be the actual transcribed minutes, or will these be condensed into summaries?
No, so whatever report is submitted by each TAC is what will be sent to the MAC members. I know there's been a question from several of the TACs about the transcripts versus meeting minutes. Prior, we had a previous court reporter who was willing to provide minutes that was not necessarily contracted work from the department, but for some tax, they requested minutes. And so she prepared those. Unfortunately, our contracted court reporters that we use now do not provide minutes. So the transcript for most of the tax have been what has constituted the minutes of the meeting. And so, there should be reviewed, and if there are any necessary changes that should be noted in the next TAC meeting. We have had some problems and we're working through those on the timeliness of receiving those transcripts, but we are committed to providing those to each meeting, to the members of each meeting 30 days after. So you at least have at a minimum 30 days to review those and note any necessary changes. If tax certainly, and again, it's kind of all over the board. Some chairs do their own minutes, but the transcript. So as at a minimum, the transcript will serve as the minutes, but certainly tax are very different, and how they utilize that information and turn them into minutes.
I just wanted to forewarn Sheila that she may be getting a whole lot of information.
I appreciate that. Thank you.
Well, I might be really interested in reading it all. Thank you. I just think I think it's very helpful to know what different areas of providers and consumer representations are looking at and discussing, even if you don't have a recommendation, because I think it gives you a sense of what are the issues that are bubbling up out there, and are they being heard from other parts of the DMS world.
Yeah, you'll have a lot of bedtime reading, Sheila.
Okay.
You get the transcripts.
Thank you for the warning. No, I don't want the transcripts.
Right. So to clarify, Barry, what generally when there's a report made from a TAC, there is something typed up, 1 page or 2 pages typed up that the chair sends as the actual report.
Okay.
Yeah, I was not volunteering to read the transcript. I barely skimmed through the ones for behavioral health, Barry, so thank you.
You're welcome.
Right. So just to summarize, in the past, we did receive the reports that the TAC submitted. We have not received those in a while. So if the TACs do submit a report, then that will be disseminated then to all the MAC members. And then the recommendations, the response to the recommendations from DMS should also be sent to all of the members. Okay, next up is questions from the MAC for Aetna or Anthem on their previous presentation from May. Any questions? Okay. Then we'll move on to the reports from the MCOs, and we probably need to limit those reports to no more than about a little over 15 minutes so that we can get through the rest of our meeting. First up is Humana.
Good morning. My name is Jeb Duke. I'm the health plan leader for Humana Health Horizons. I think if you give us control of the screen, maybe we can bring up our presentation.
Okay, I've just made you a co-host. You should be able to share.
Awesome. Well, I think Rebecca Moran will be sharing her screen, and if she can't, I will figure out the technology and bring it up. All right, well, let me go ahead and try it.
I think I might have to be made co-host. Oh, there we go. I just got access to it.
Perfect. Well, thank you again for the opportunity to speak. I think we had planned to keep our comments to around 15 minutes. There's a lot of data that the MAC requested, and what we've done, I think there's 33 slides. We've put all the core of the data requests into the appendix. So we'll be available to answer questions after our comments or during the next MAC meeting to come back with any specific requests. Humana was founded in Kentucky. We remain a Kentucky organization. As we think about Medicaid, we've been in the Medicaid program in Kentucky since 2013, but this is actually our 3rd year of being a fully integrated health plan with all Humana resources. What that means is every part of our organization, from a process perspective, from an organizational perspective, is made up of Kentuckians. If you call us, our provider call centers, our member call centers, our claims adjudicators, our clinical intakes teams, our physicians and our nurses are all Kentuckians. And we're here to support Kentuckians with a high level of focus on doing the right thing. From our perspective, our membership is split 50-50 between urban and rural. But since we joined during the expansion of Medicaid, what we have found is that primarily compared to the other organizations, we serve more members through expansion. And through that, we have a much higher prevalence of members with substance abuse and opioid disorder use. And you'll find that in a lot of our programming is really focused on clinical care for adults and people with high acuity and chronic needs. If we want to go to the next slide, we're going to spend a little bit of time talking about benefits and what value-added services or expanded services are. Rebecca, next slide. Well, I'll keep going. Expanded benefits are benefits that go beyond fee-for-service Medicaid. So there's things that address social determinants, there's things that address access to care, and really things that are geared towards creating interventions to ensure members have access to preventative care. One of the things we do is a workforce program. So in our workforce program, we do things like employment coaching. We provide reimbursement for our members who need daycare during an interview. We provide transportations to interviews. We provide reimbursements for GED testing, and we provide reimbursement for criminal expungement. So the goal is to find people who want to get back to work and wrap resources around them in order to get them back into the workforce in Kentucky. In addition to that, Humana has recently announced we're going to be hiring 200 new associates in rural Kentucky, really geared towards those communities that were impacted in Western Kentucky through the tornadoes. If we think about our basic needs programs, again, expanded benefits, we offer additional access to cell phones. That means you're going to get more data, you're going to get more talk time, and you're going to get more text, so that there's no reason a Medicaid member enrolled with Humana is not willing to either pick up their phone and speak with us or to one of our case managers, or they're not willing to use their data to use one of our digital apps to access key information for their healthcare. We also do things like sports physicals. And one thing that I'm really excited about, and it's from a timing perspective is pertinent, we're now offering free back to school haircuts. So any of our members enrolled in Humana can go get to the barber shop or to the beauty shop before we go back to school, and they can show up ready to learn on day one. We also offer a significant expansion for wellness programs. So things like diabetes, tobacco cessation, weight loss programs, or 24/7 access to a physician. All of these programs can have interactive video-enabled digital access for our members for clinical programming. In addition to that, we do programs for pregnant women to include our rewards program, support with breastfeeding. And one thing that's somewhat unique is that we're now offering access to doula services. So if a member wants those supports during their pregnancy, they can come to Humana and we will reimburse providers for access for the services. Rebecca, next slide. Part of our rewards program, if we think about expanded benefits as well, is our access to rewards programs. So at Humana today, a member can feasibly get $540 of rewards, gift cards, for doing things like preventative services, vaccinations, or participating in our programs for pregnancy. I'm excited about what this opportunity provides when we think about incentivizing members to do preventative care and improve outcomes. What I'll tell you is we're going to do more. So we're looking at our benefits for next year. We're going to increase it. We've seen the impact it has on our quality programs and our Hedis. We're going to double down on it. So we want our members engaged in their care, and we want tools that are available to encourage them to do that. Next slide. So from an operational perspective, and I think we provided this in the MOAC, so a lot of attendees, I think, attend the same meetings, but network is important to Humana. So the #1 job that we have as a health plan is ensuring that our members have access to physicians and access to care. From Humana's perspective, there's across a slew of provider taxonomies, we offer every single provider that has a Medicaid ID in the state. That includes all acute care hospitals, includes all CMHCs, long-term care hospitals, inpatient psychiatric, critical access hospitals, FQHCs, psychiatric residential centers. In addition to that, we have over 6,000 PCPs, over 700 OBGYNs. And when you compare Humana's network from a specialty perspective, we believe we offer one of the broadest network to specialty care. So when members' needs have high needs, they can come to Humana and they can have access throughout our network. Across our next slide, how do we maintain that network? So you can build a network, but it truly does have to be maintained. I know we talk about a lot in the MAC about, are we meeting our time and distance requirements that are within our contracts with EMS? At Humana, yes, we are. We plot our members on a monthly basis, ensuring that time and distance to all contractual required physicians are meeting those standards. But we're also surveying our providers and members to get feedback and recommendations for improvements. We're also using tools that would suggest to us on a monthly basis what providers are in our other networks, so our commercial or our Medicare providers that may be good targets to bring into our Medicaid program, and also providers that exist on the master list from Medicaid that don't exist in our network today, so we can reach out to them to contract. And lastly, we look at utilization. So we talked about the non-PAR process a little bit earlier today. So we look at our members' utilization and requests from providers to have a single case agreement. And what we do is we can convert those single case agreements and make them participating providers within our network. Next slide. So we're going to talk a little bit about population health and our clinical programs. Kristen Mauder, I'll do a handoff to you.
Hi, this is Kristen. So I'm going to talk with you about population health and the focus we have on that. The core of what we do as a health plan is to use our data sources to create various risk stratification methodologies. Those could be like identifying chronic conditions, our prediction of what we might want to see, and severity models to generate those risk levels. And these risk levels then inform our outreach for case management and SDOH supports. Through this identification, we attempt to help members focus on making better decisions, encouraging them to work with their healthcare providers, promote prevention activities, address SDOH needs, and reward for their healthy behaviors through their Go365 programs, which Jeb just talked about. So along with what you saw on the other slides, we reward for those preventative and quality visits, such as the prenatal visits, postnatal visits, child visits, diabetic screenings, and then offer those SDOH activities like our workforce development program and housing assistance. Next slide, please. So this is where we're going to talk about incentives aimed towards improving our health. And so Jeb talked a little bit about our Pacify and our VITA programs. And so our Pacify program is for, prenatal and newborn support. What we've seen in that program as far as outcomes is that we've seen a 12% increase in our prenatal visits and a 15% increase in our postnatal visits. And we use this program in conjunction with our Moms First case management program. With VITA, that program is geared towards our pre-diabetics and our type 2 diabetes. And so some of the outcomes we've seen with that is our medication adherence increased by 50% and PCP visits up to 29%. And so that can be a self-serve application, or we can also refer from our case management chronic condition program. Some of the other things that we have going on in population health is our VOA partnership, where we're using community health workers along with the community health workers that we have. And they are in a targeted 6 zip codes within Louisville that they're focusing on for us. We also have some programs around ER diversion. And so we have MD Live Access, which is a telehealth access. And that's to help promote diversion from ER or urgent treatment when those are levels of care that really aren't needed for what's really going on with the member. Our Where to Get Care program is multifaceted. So that program is where a member goes into the ER and they get a letter or like a flyer that talks about, reasons to go to the ER, when to go to your PCP, when, maybe the telehealth might be important, all of those things. And then also gives information about how to outreach to our case management if they need additional support. Then with our HIE expanded integration, we also look at that data around ER visits as well. And then we give those, we're identified 24 hours after that visit and turn those over to our case management team for them to be able to outreach and help them with whatever needs they may have. From a quality perspective, we've enhanced our SDOH assessment. So we have questions in our different assessments when we do outreach around SDOH. And then we also implemented what's called the Prepare, which is very SDOH specific. And then we also educate our providers on that Prepare as well. Here recently, we've began additional work on colon cancer screening. That's related to the PIP that we have going on, which is a project improvement plan. And we're working on being able to send out in-home test kits around colon cancer screening. And then as Jeb mentioned, we have the Go 365 rewards to reward for those healthcare pieces, and then also, SDOH, and they can get up to, $500 in incentives around that. Let's go to the next slide, please. So here we're going to talk about addressing care gaps. And so that's gaps in care related to like our HEDIS and quality. And as you can see, we've had some year-over-year success in working with our membership on improving those. So we just put on here some of our basic, healthcare pieces that you look at. So like our comprehensive diabetes care, we've seen great increases in that. Our prenatal and postnatal visits, we see increases in that. Our child visits, we've seen increases in 2 out of the 3, and we're doing interventions to help focus on that 15 months to 30 months to be able to help increase that. And then we've also seen increases in our weight assessment and counseling. And so through that data integration that I talked about before that identifies members for outreach, we have processes in place. When they do get a hold of them, they do a preventative screening that addresses all of these gaps in care. We're also looking at our data integration to make sure that we're picking up all of the claims data and HIE data to give credit for those to help close those gaps. And then, like I said, putting that information in our assessments to make sure that we're really identifying and working with the members when we are able to work one-on-one with them. So I will go to the next slide, please. And I will turn it over to Brent. Thank you.
Thanks, Kristen. And we just have a few more slides as we wrap up the content we had prepared today. What I would add is, as Jeb mentioned, we've got a pretty heavy appendix with a lot of content that specifically answers a number of questions or requests in the original list of items. So that will all be in the broader presentation slide deck. Just as we close out, we did want to touch on a couple quality recognition programs. We engaged with our primary care provider network with 2 programs, the model practice and the quality recognition program. These are both incentive-based, and they require our primary care physician groups to and their member panels to meet certain quality measures. These quality measures, the targets themselves are developed annually, and depending on whether you're eligible for the quality recognition program or the model practice, you're eligible for incentives calculated on a per member per month basis, and that could be payable on a quarterly and annual basis. I think the important thing as we think about the value of these programs, they do create an opportunity for increased engagement between us and the provider community. They definitely increase the amount of reporting and data sharing between us and the primary care providers, and ultimately just greater alignment between all the healthcare stakeholders on the quality-focused initiatives that we're all focused on. The last thing I would say here, when we talk about the scope and the reach of these programs, 90% of our members are aligned to PCPs that are eligible to participate in at least one of these programs today. And so we can go to the next slide. And so the last slide in our prepared content, we did want to acknowledge COVID vaccination rates and our process to both quantify and maintain a status for all of our members, and how we've used that data and other incentives. The first thing I would say is, for 18 plus months, we've been integrating a broad array of data sets, right, to get that single source of truth across the members we serve and understand their vaccination status, to continually refresh that data and understand at an aggregate level what the vaccination rates are across the members we serve, across the number of demographic segments. a lot of the trends we see are the same trends that I think the other MCOs would see as we look at the broader Medicaid population as a whole. You know, we see higher vaccination rates among higher age bands. We see higher vaccination rates among certain regions, specifically regions 3 and region 5. You know, this tracking and trending has been important over the last year and a half in the aggregate, but I think a lot of the value has also come from the way in which we track and trend this at a member level and how we allow this information and this analytical process to drive downstream outreach, education to our members, inquiring, are there barriers that an individual has to becoming vaccinated that we can help remove? And so we pair a lot of care management, outreach and engagement with our members. And we've paired that with, and all MCOs have offered incentives to some extent for becoming vaccinated, and we have too. So those have been in place. The last thing I would say, we still see, you know, a material proportion of our members that we don't report being vaccinated, and we see that across the program as a whole. But one thing we did in Q3 and Q4 of last year was to actually develop a study and engage with our members that were unvaccinated. So a study specifically on the members we serve, inquiring from them, you know, their thoughts on the vaccination, and if they are truly hesitant, you know, what are those reasons? So we wanted to understand from their perspective how we might be able to tweak our approach through incentives or outreach and better understand barriers. We do see among those that indicated they're still not vaccinated and they're hesitant to become vaccinated, a lot of the themes that we see nationally throughout a lot of studies, you know, a lack of trust in the vaccine, concern for the side effects, and then just the way in which, you know, the rapid development of the vaccine occurred. You know, some were kind of still on the fence, trying to understand maybe later, but not yet. We want to see as more data comes in. So just another way in which we wanted to engage with our members and understand from their perspective any hesitancy. So I'll pause there. That is all the content we had prepared for the main presentation. As I mentioned, we've got a lot of content in the appendix to answer a number of other questions.
Thank you. Anybody have questions?
This is Dr. Bobrowski. I've got just a couple. And I'm a Humana dental provider, but I noticed you mentioned on one of your slides that there were some expanded dental benefits, and you don't have to take time right now, but if I could get some information on that. And then the other question I had is, do you have quality measures for dental on, you know, like receiving these quality bonuses? I know you've got them set up in other health areas, but I haven't seen anything for dental. And you can email me, or I know we're short on time today.
I appreciate the question, and maybe we can follow up with some more detail. So one thing I would make sure that we're being transparent on is there's a Humana dental network that supports our commercial and Medicare members. And in the Medicaid space currently today, we do partner with Avisis. So the Avisis contracted rates and the Avisis network are different than the Humana dental network. And that's something, you know, we're looking at long term. But in regards to enhanced payment, we don't currently have an enhanced payment program for dentists, but we do reimburse to primary care physicians mostly, and are moving into behavioral health. You know, I think as managed care continues in the state, we'll look at other specialty provider types to figure out where we can move the number on quality. And I'll get some more detail on those responses.
Thank you.
Thank you, sir.
I have a question about the meals program. How are meals provided in rural areas to participants?
A great question. So our meals program is for members who are discharging from the hospital. Those meals are sent to the members frozen. If they request it, we do have shelf stable. So when there's issues with refrigeration, we can provide alternatives. And also during COVID, we opened that up. And also during the response for Western Kentucky, we opened that up to all members. So in times of emergency, we provide extra access to food In others, it's to improve and reduce readmission rates. But primarily the mechanism is via mail, UPS, FedEx.
Okay, okay, thank you. And then the other thing is, can we make all these slides available, sent to the MAC members and then also available on our website so other stakeholders can?
Absolutely.
Okay, thank you. Any other questions? Okay, thank you very much. And we will move on to Molina and Passport. Do we have?
Hey guys, that's my cue. This is Ryan. I am hopping online just to dial in a couple of folks here this morning, check on them from the flooding. I see Dr. James on. Meredith, are you on to share our presentation? Thanks.
I think I just need to be made a co-host as well, Brian.
I just added you as a co-host.
Okay.
This is not a halo. I just have a glowing effect on top of my head. So anyway, I apologize for the screen here.
I think it's starting to share maybe.
Dr. Hannah, I see you there.
Okay, can you see my screen?
Not yet. Not quite yet.
Just thinking about it. Okay.
There you go. Good. Okay, well, by way of formal introduction, my name is Ryan Sadler. I'm the plan president and CEO of Passport Health Plan by Molina Healthcare. I think all you guys know, the parent company of Passport is Molina. Molina is a large Medicaid organization, actually based out of California, but we operate health plans, I think it's 19 some odd states across the country. And so, of course, here too in Kentucky. I'm in Louisville. And as are most of our staff, although we do have staff scattered throughout the Commonwealth, we've got around 700 today, and we're hiring. We're looking for another 400 or so staff to join us. So you may see or hear that out in the community. And we can go ahead and advance to the next slide, please. I'm going to tee this up in terms of some introductory comments, and then the real subject matter experts on the team will chip in and provide some detail, but happy to answer any questions along the way as well. So look, Passport's been around and Molina has been around for quite a while. On the Molina side, we started as a provider-oriented organization. Started and founded by Dr. Molina, specifically operating clinics for low-income individuals. And that's been the basis upon which we built Molina, and that we've expanded in that way. So our sole focus really is government-sponsored healthcare, predominantly for the underserved and underprivileged. It's the lens through which we think about our entire business. We do operate a small plan on the marketplace in exchange. We also operate a small Medicare line as well. But it's really intended to be supplemental to our members that might need access to care as they move through the continuum, not necessarily to be our primary focus. So in Kentucky, it's probably 99% Medicaid focused, and then we have a home for folks to land if they need access to our services beyond Medicaid. But look, central to our model is intended to be a provider-focused orientation. Our company ceases to exist without our provider partnerships. And if we're doing business well for you, then you'll be able to do business well, for our patients and our members. And so we try to be mindful of that as we're working in the community. And hopefully you're finding that working with us, there is some ease at which to do that. If there's not, then that's on us to address, and constantly want that feedback to the extent that we need to make some changes. We want to be open to that. Next slide. These are just some of the commitments that we've made to the Commonwealth, and we continue to deliver on. I mentioned our 1,100 jobs in our staff locally. One of the beautiful things that we've got going on right now as a result of the pandemic is that as people are backfilled, not terminated, but let's just say they resign for one reason or another, wherever they may be in the country, I can backfill those people here in Kentucky, oftentimes in a financially advantageous way, but also, selfishly, because I want to, build a bigger and better presence here in Kentucky. And so as we're doing that, we're saying, we don't need all 1,100 jobs for our health plan, so to speak. But we've got plenty of room to hire them for the enterprise at large. So we've got sort of this regional operating model, which is supplementary to our health plan operation as well. So that's how we're able to staff as many people as we do. You see our membership number, it's about 330,000 members. And just if you could go back real quick. Of course, our network, no surprise, like most of the Medicaid MCOs, we've got a significant number of providers and systems. We are really an enabling provider operation. So if folks want to participate in the Medicaid program, we want you in the network. We've tried to be as open a network as we can. And then just finally, our multi-million-dollar investment and contribution strategy through our community organizations. It's something we promised to do when we came here, and we're delivering on that every day as we support our folks that need help. So let's advance to the next slide. This is really just a small victory lap. I'm pretty excited about this. We were nominated through Louisville Louisville's best places to work through Louisville Business First. And so anyway, there's 50 organizations on the list. And I say this and I raise this just because in this world of remote setting, trying to create some sort of culture where people want to be here, they want to contribute, they want to focus on member services and taking care of our patients. It's harder and harder every day. And so drilling down into how we create a culture of folks that are excited to be here and choose to be here every day is a big priority. And in turn, that I believe generates better outcomes for our patients and our members. Next slide. Go ahead. I think we can go back one, but just a quick note. We do try to incorporate these remember the member slides and stories into our presentations. There's a lot of this internally, but it's important for us on the insurance side, on the payer side, to step back and remember what all you guys see every day on the front lines as providers, just how we are impacting the lives of the members that we serve. And for some of us, we can actually have that personal interaction with the members. But for most of us on the payer side, we're back office. And so trying to remember the mission that we're all here to serve, which is patient care, is got to be top of mind. And so this is just an example of how we're trying to connect our people to that member interaction. So this will be in the slides, and I don't want to read it to you, but please feel free to review it, and you'll get a sense of kind of how we interact. And in particular, this story is about our tornado relief, which is all the more pertinent today in and around the flooding relief efforts that we have going on as we speak. So just at a high level, we're reaching out to every staff member who lives in the impacted communities over in Eastern Kentucky right now. We're texting and calling all of our members that are impacted in these counties that live there. We're cross-referencing those members with anybody that's been in active case management. We're making direct outreach to those folks to make sure that they're doing okay. We're cross-referencing that with any member that has received a prescription in the last 30 days under the premise that maybe their prescription that they need is now gone because of the flooding. And how do we make sure they have access to an emergency fill and the like? So there's a lot of outreach happening as we speak to make sure we're connecting the dots where we can. And in some cases we can't help. And in some cases we are able to connect those dots for folks that are, lost power and in the coming days may still have lost power and just need access to food that can stay, non-perishable. Anyway, lots of work going on. This is a good example of that from the tornado relief perspective, but it's really the playbook we're following again today in Eastern Kentucky. So if I don't make it clear, our thoughts and prayers are with our folks that are out there now, because some of them are going through some tough times. Next up is our membership slide. This gives you a breakdown of where our members are, age ranges and the like, based on region. Clearly, the majority of our membership is in the Louisville area, but you get a sense there of the breakdown as we look at our footprint across the Commonwealth. Look, I'll just tell you just briefly, particularly for our provider partners, I have a real sense of commitment to making sure that our services are available just as much in the east and west part of the states, as part of the state as they are in Louisville. I think it's really important that, if I believe that our services we're providing are great, maybe even exceptional, I want to make sure that those same services are available to our members, in the rural parts of the Commonwealth as well. And so I think I have an obligation to make sure that I'm doing as much there as we are here. And so you'll see that kind of come through in the slides and hopefully over time as we continue to grow. All right, I'm going to turn it over to our quality folks. So make sure we got our quality team on.
Hi, good afternoon. This is Leslie Anderson. I'm with the Quality Interventions team. Can move to the next slide. All right, so we completed our preliminary 2021 Hedis data and compared that to our performance from last year, and we're seeing an improvement in over 60% of our measures across the board. So we're very excited about that. Some of the areas that we've seen the greatest improvement in are the diabetes A1C control, and that's really a reflection of the work that we're doing for the Diabetes Management Performance Improvement Plan. And also we had a big push this year to try and get folks back in to see their PCPs, especially since a lot of people sat out in 2020 because of the pandemic. And we're seeing that the efforts that we put in are really working when it comes to our well care visits for our kiddos. So across the board from birth through adolescence, we saw improvement. Prenatal postpartum is also a focus measure for us, and we have a maternity care program as well as some value-added benefits, and we're seeing that pay off in improvements for our timeliness of prenatal care. And then also our follow-up after hospitalization for mental illness. This again is kind of related to the work that we're doing for the performance improvement plans. This one for the social determinants of health. We have an enhanced discharge planning process for those folks that have been hospitalized for behavioral health, and we're seeing great improvements there. We've also identified some areas that we are focusing on for this year. For the cancer screening, we have started a partnership with the American Cancer Society, and we are identifying barriers for folks and strategizing ways to get people to get those cancer screenings completed. And then we are also focusing on the entire behavioral health domain of care as a focused opportunity for us this year and moving forward. Next slide, please. And this is just a year-over-year snapshot of our Hedis performance. Again, 2019 and 2020 were before the Molina acquisition. But as you can see, we have made improvements across the board. For that last one there on the chart, the well child visits, the Hedis measures changed moving into 2020, which is why we omitted 2019 since it wasn't an apples to apples comparison. But again, improvements in all of those domains of care. We're also very excited that we have launched our value-based contract on January 1st of this year. We are currently, it's a targeted rollout for certain providers, and 51% of our membership is actually already covered by the value-based contract with the provider groups that have signed already this year. It is PCP focused and it is quality driven. So that is a lot of Hedis performance. We're looking at NCQA and plan performance. And then, of course, it's patient-centered. So all of the reports that we're giving our providers can be drilled down to the member level so they can see exactly what each member is in need of as far as screenings and services. And we also have an SDOH-Z coding component as part of our value-based contract that allows us to kind of get the more holistic picture of the member outside of just physical health. Next slide. And then this is a snapshot of our value-added benefits program. We have a very robust program of extra benefits and incentives that we offer our members. So like I had mentioned previously, prenatal postpartum is a focus for us. So we do offer our members an infant carrier or a car seat if they have a prenatal visit in their first trimester. There's also lots of opportunities for earning gift cards for well child visits. And then on the bottom there, it says diabetic A1C screening, but we actually offer a number of diabetic benefits. So we have A1C screening. We also have a gift card for eye exams. And then new as of January 1st of this year, we're offering a $25 gift card for our members that complete diabetes self-management and support classes, just to help support that effort to drive our diabetic members to the resources that are available to them. Next slide. And then again, these are some just additional benefits. The health risk assessment, the $25 gift card there was also a new addition that was added at the beginning of this year that helps support the efforts again for the SDOH performance improvement plan. And it also helps us to get a more complete picture of all of our members. And then there are a number of gift card incentives for cancer screenings. And it's not listed here, but we do have a value added benefit of a free fit kit for at-home colon cancer screening for all of our eligible members. And I will sign it over to Stephanie.
Hello, I'm Stephanie Stone. I'm our AVP of Healthcare Services here at Passport, and I'm going to move quickly through my slides because I know we are very short on time, but I am happy to answer any questions today or following today that any of you may have. This slide just shows that we are leading the charge. We are the first health plan as far as the percent of our vaccine eligible members who have received a COVID vaccine. And of course, we slice this and look at it in many ways. We have multiple interventions to try to increase vaccination rates, and it is always a focus too. And especially now that the 6-month and older crowd are now eligible for the vaccines as well. You can go to the next slide. Our care management services are of course individualized to the needs of every member that we serve. We have different acuity levels that basically increase the intensity and frequency of the work with our members based on the needs of those members, with level 1 being lowest acuity, focused more on health education, and level 4 being the most intensive services that we provide. And all of our services in care management are focused on helping to improve our members' health and quality of life. Next slide. This slide just illustrates that we have a large multidisciplinary care management team. It includes licensed clinical professionals as well as certified community health workers and certified peer specialists working within our team. Next slide. So related to one of the aspects related to social determinants of health, every health risk assessment that is sent to our members initially and annually include questions related to social determinants of health. Those questions can trigger further interventions such as depression screening and additional care management services. All of our members that are in care management, effective January of 2021, complete the Prepare SDOH screening. I know Kristen mentioned that earlier from Humana. We have been doing that since January of last year as well, to help us further identify barriers to our members accessing healthcare. Next slide. Our community engagement team works with a wide array of advocates in the community to identify barriers at that community level. The slide is just illustrating some of the factors that are being influenced by these collaborative efforts. Next slide, Meredith. We have, as I mentioned before, certified community health workers. We call them community connectors. We also have housing specialists who do exactly what you might think. They're working to address any and all barriers and needs that our members have related to housing. We also have certified peer supports that Dr. Hannah is going to talk a little bit more about in a minute. But these roles, I kind of look at them as helping to provide families and members with that first meal of fish so that then we can go on to teach those individuals to fish once they have the full belly. So we have a collaborative related to social determinants of health with U of L's Peace Hospital. We've been working to facilitate enhanced discharge planning to include social determinants of health related information. I won't go into a lot of detail due to the time, but I will say this has been a successful project. And because of this success, we're expanding this to include another treatment facility in the next month or so. You can go to the next slide. So I do want to spend a little bit of time here. This is our emergency housing voucher program that we're very proud of. The Louisville Metro Housing Authority and the Coalition for the Homeless came to us last year with an identified need. They had a grant to provide emergency housing vouchers, but one of the stipulations of that grant was that they needed to have housing navigators to be able to walk individuals through the process and ensure their success before and after receiving the emergency housing voucher. There was a staffing need. There weren't enough housing navigators to be able to accept all of the vouchers and give them to individuals in our community. So we at Passport agreed to allow our housing specialists and community connectors to act as housing navigators for any of our members who happen to be eligible or receive one of those vouchers. This took the burden off of our community partners and allowed them to focus their housing navigation efforts on our individuals that weren't Passport members. And we took on carrying the load for our members who were receiving these vouchers. You can go to the next slide. So as a result of this, there were 200 emergency housing vouchers that were awarded within the Louisville community. 103 of those went to Passport members. We currently have 26 members that are in active housing navigation and 45 members that have been housed. Note that that number is only our members, not their children or partners that may have been housed with them. So the actual number of individuals housed is much higher than that were impacted by our team being able to step in and provide these services. Next slide, Meredith. So what we gained from this, besides helping individuals, of course, was strengthen partnerships with our community agencies that serve those experiencing homelessness or those at risk of losing their housing. We gained invaluable knowledge about navigating those systems within at least this part of our state. And due to the success of the collaboration that we had on those emergency housing vouchers, we've been asked to partner on a new project serving individuals who are experiencing homelessness and living in homeless encampments. So great success overall, and we're excited to see where it goes next. And I'll turn it over to Dr. Hannah.
And I see we're at time. Can I just check and see if we're to continue on here or what the, I just wanted to, well, I'm going to keep going.
Yeah,
if
you can keep it real short, because right now we're at time for our whole meeting and we still got a couple other points to make. So if you can make your points real quick and then just share your slides after.
Okay, that sounds good. I'm going to tell you two things about peer support specialists. First of all, Passport is innovative in the fact that we use people with lived experience, that is, people who have actually experienced a substance use disorder or mental illness as staff to do outreach. And we have our staff are in recovery, but for those conditions, being in recovery doesn't mean that the condition is in the past. Chad Cordial, one of our peer support specialists, lives over in Rush. He says to me, Dave, I've been sober for 13 years, but every single day it's a decision. But what's important about that is when they reach out to people, they become a living embodiment of hope for our members who are struggling with use of substances or mental illness, that change in their life is possible. And our goal of our peer support specialists is that they will engage with people and help them get connected with the services they need. We're not trying to replace or duplicate services in the community. And their outreach is explained in the slides that's here. We are really focused on reaching the people that can't be reached. I'm just going to tell you this, Tammy Hedges, another one of our peer support specialists who lives in Louisville. And we were talking about going into the community as COVID began to ease last year. And, you know, some of the places that our peer support specialists have to go aren't the most attractive places. And she said to me, she says, Dave, I'll go anywhere. She says, I know what it was like not to be able to get myself to help. And so that's what we're trying to do with our peer support specialists. They work with members with opiate use disorders and our high emergency department utilization, really trying to connect with people to help them get the help they need. And Meredith, I think you can move on.
Hey, I think we'll probably
Eastern
just
Kentucky is wide open.
Yeah, from the passport side, I think we'll just wrap and we'll submit our slides to you guys. And if you have any questions, happy to answer them or reconvene next time.
Okay, thank you very much. So again, if the slides can be shared with all of the MAC members and also put on the website for stakeholders to see those. And then if we have questions at our next meeting, we can bring those up. Does anybody have any questions now that they would like to ask? Okay, then moving along, next item is election, and we have 3 people for each slot who have submitted their names. Myself as chair, Dr. Bobrowski for co-chair, and Teresa, did you submit for secretary again?
Yes, I did.
Okay. Did anybody else want to submit their name for nomination?
We didn't receive any other nominations, Dr. Parton.
Okay, thank you. Then we'll just do a voice vote in favor of these 3 candidates.
You need a motion to accept the slate?
Yes.
Pardon?
Yes, please.
I'll make a motion to accept the slate as submitted.
And this is Ken Gilbert. I'll second it.
Okay. Josh? Okay, all in favor, say aye.
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 Anybody opposed? Okay, so our chair, co-chair, and secretary will remain the same for the coming year. We have one item of new business, and Dr. Gupta has some points and questions that she would like to raise.
Thank you, Dr. Parton. My question for DMS and the MCOs is, how do the organizations plan to handle the fallout from the abortion ban in Kentucky? Specifically, there's an estimated general overall increase expected for maternal death. That's an overall increase of about 21%, with an increase in non-Hispanic Black women of about 33%. So this means that year over year, up to 33% of non-Hispanic Black women are expected to die in some regard to pregnancy. Also, how are the organizations planning to take care of the increased foster care demand financially, which will also increase the poverty rate, which equals increased violence, which also increases the death rate? There will be less women working, increased mental health illness, decreased access to healthcare from OBGYNs. Already in the state, there's not, I think 50% of the counties do not have one OBGYN. And then lastly, what how is DMS and the MCOs planning to help women who are Medicaid recipients obtain abortions across state lines? Will they help with transportation? Will they help finance paying for the abortion? So those are just some things I've been thinking about, and I'm pretty sure you all have been thinking about it too. And you don't have to answer it now. This is for maybe some future meetings.
Thank you, Mr. Gupta. So if DMS could, that would be a recommendation or request from the MAC for DMS to respond to at our next meeting. Does anybody else have any other business that they would like? Oh, somebody just made a comment.
Just a
Chair
concurrent.
Partner. This is Barry. I just want to give kudos to DMS. They've been doing a lot of really good things, especially over the last year, 2 years. And I think sometimes we get lost in the things that we need and want. And I think they've done a really good job. And I like to tip my hat to them. I mean, can we do better? Of course, but we can all do better.
Thank you, Barry. And I agree. It's been a pleasure to work with Commissioner Lee and Deputy Commissioner Cecil. They have been very responsive to our concerns and our questions and any recommendations and also engaging us in discussions about future issues. So yeah, I would like to echo your comments.
Yeah.
Madam Chair, this is Sheila Schuster. I would like to thank Dr. Gupta for so comprehensively outlining many of the issues and concerns that many of us have had. And I appreciate her bringing that forward to put on our agenda for the next meeting. And also want to reinforce what Barry just said. The Medicaid staff has been, I think, immensely responsive in so many ways. Some of us are working on separate issues like the SMI waiver and the SUD waiver and so forth, and just have found the staff to be ready and willing to meet with us and explain what's going on and keep us in the loop. So I appreciate that.
In response to Dr. Gupta's question, we have been discussing the issue internally and with some of our MCO partners. We don't really have an answer for you right now, but we welcome the chance to talk about this at the next meeting.
Thank you. Okay, so I will put that back on the agenda for the next meeting. And hopefully by then we'll have some feedback. Okay, so this has been a busy meeting. Does anybody else have any other issues that they would like to bring forward? Okay, then can we have a motion to adjourn?
I'll make a motion to adjourn.
I second it. This is Teresa.
Thank you, Teresa. Any discussion? Aye.
Thank you. Bye, everybody.
Thank you all.
Thank you.
All right, meeting adjourned. Thank you.
Thank you all.